Okay, moving on with GI stuff. So now we're going to move into chapter 47, and we're going to move a little further down in the GI tract, and we're going to talk about the stomach and the duodenal disorders. So in this chapter, I think I told you in the last chapter about H. pylori, which is Helicobacter pylori, which is in this chapter, and it's in the glossary, so it can. So I do want you to be familiar with that. We're going to talk about some of the bariatric problems because this is a growing problem in the United States, and many of you will end up working in bariatric centers and taking care of patients who have postoperative bariatric surgeries. So we're going to talk, those are kind of the things, and then some of the ulcers, the stomach ulcers, peptic ulcers, things like that, because those are also fairly common. Okay, gastritis, that's just inflammation of the stomach. You've all had, if you've had the flu, you've probably had a little bit of gastritis. Okay, so the thing I want to talk about is ulcers. And it looks like the whole first couple pages is gastritis, and then it talks about peptic ulcer disease on page 1265. So that's what I really want to focus on, is peptic ulcer disease, because that becomes a little bit more problematic. What happens in a patient who has gastric or peptic ulcer disease, and those words are used interchangeably. Peptic ulcer disease is just stomach ulcers or gastric ulcers. It's the same thing. Basically what happens is that the stomach content is so high, it starts eroding through a certain place in the stomach, and it can cause an ulcer, meaning the lining of the stomach starts getting thinner. The problem that you worry about in patients who have ulcers is you don't want that ulcer to perforate, meaning going all the way through the stomach. You don't want it to bleed, and you want it to heal. So if a patient has, usually stomach or peptic ulcer disease has a lower pain, and it's a little bit of different pain than GERD, where GERD kind of is like heartburn right up underneath the heart. Peptic ulcer disease is usually more of a sharp stabbing kind of pain. And sometimes it's worse if the stomach is empty because there's no food in there to help absorb some of the acid. The acid just sits on those ulcers. The treatment is very similar. They use a lot of proton pump inhibitors or antacids, or all of the same kinds of drugs, which I want you to know. On table 47.1 on page 1264, I do want you to be familiar with what are the H2 receptor antagonists, which ones are the PPIs, the proton pump inhibitors, and the different antibiotics and stuff, because those are really important in the treatment of peptic ulcers, gastritis, H. pylori, those kinds of things. So I'm not going to read all of them to you, but you need to be familiar with that table. Really important. Okay, so it depends on how severe the peptic ulcers are, and typically people that get one are more prone to getting them. People who have high levels of stress, and they do all the things that I just told you in the other chapter to not do with GERD, like they drink a ton of coffee, they smoke, they drink a lot of carbonated beverages. Those patients, and sometimes they just have a genetic predisposition to having stomach ulcers. Well, if that gets so bad, a couple things. One, if a stomach ulcer erodes an artery and all of a sudden the patient starts vomiting bright red blood. Typically, if your patient is vomiting bright red blood, typically the esophagus has eroded. It's like an ulcer at the bottom of the esophagus, and it's eroded into an artery, and then you have bleeding that way. If a stomach ulcer starts bleeding, the blood from the ulcer will mix with the gastric acid, and the mixing of the two creates a substance that looks like coffee grounds. So and then they start vomiting something that looks like coffee grounds. That is probably a bleeding ulcer. Somebody's having a bleeding ulcer and they're bleeding up they're vomiting up coffee grounds. That's a medical emergency. You need to get that person to surgery, or at least put like some kind of a tube, like a stink off tube in there to put some pressure on those ulcers if possible, so that your patient doesn't exsanguinate. So keep those in mind. Now, here's the other thing. If your patient has an ulcer and it's just a slow bleeding ulcer, or just trickling a little bit, a person might not vomit. You might not know that, but that's when it could show up in a guaiac, when you guaiac the stools, because those little microscopic pieces of blood, because you should not have blood in your GI tract, it will trace all the way down into the stool, and you guaiac it, put the little drops on there, it turns blue. Now you know your patient's bleeding from somewhere in the GI tract. You would coordinate that with other assessment findings such as low hemoglobin, low hematocrit. Those are the two classic ones that you know that your patient's bleeding from somewhere, and then you start the GI workup. So your patient comes in, they're a little fatigued. You check under their eyes, they're sort of pale, they're complaining that they haven't been feeling very good lately, but their symptoms are kind of vague. You guaiac their stool and you find out that that is positive. So now you start the diagnostic workup. And you could start with an endoscopy. If that doesn't show anything, you could do a colonoscopy, because it could be a bleeding polyp or something like that. And that's how you kind of find that. And then once they do an endoscopy and find out, oh, you've got an ulcer there, now we can put you on a PPI and have you avoid certain foods and stop smoking and all the other things that contribute to that. And hopefully that gastric ulcer will heal. However, sometimes people who have really significant peptic ulcer disease, they have to have either a partial gastrectomy, or in some cases a total gastrectomy, meaning a complete removal of the stomach. In the event that somebody has to have a complete removal of the stomach, obviously you're going to have to find other ways to feed the patient. So these patients usually have tube feedings done in through the small intestine, and they just have to give themselves tube feedings every day because they can't take things orally. The other thing that you need to remember about your stomach is that it has an intrinsic factor in it, which is necessary to absorb vitamin B12. So when you eat vitamin B12 in the foods and stuff, when it gets to your stomach, that's how it gets transmitted into your body, because you have an intrinsic factor inside your stomach. Well, in people that don't have stomachs, they are not going to be able to absorb vitamin B12, which is extremely necessary for nerve functioning and several other physiological functionings. So in those patients, they are going to have to be on vitamin B12 injections the rest of their life. There are some vitamin B12 sprays, I don't think they're as effective yet. They probably will be. So patients who have had a complete gastrectomy, this is not true with partial gastrectomy because they still have a little bit of intrinsic factor left, but if they've had a complete gastrectomy, then they either have to learn how to give themselves B12 shots, or have somebody else learn how to give them B12 shots, or maybe see if their physician will write for the B12 nasal sprays. So that's kind of important in your patients who have had gastrectomies. And there is a good picture on figure 47.2 of a peptic ulcer. The problem with the second problem, I told you about bleeding. The other problem is perforation. If that ulcer gets so far down that it perforates through the stomach altogether, that's a very, very serious problem, because now you have all the stomach contents that are supposed to be inside the stomach are now going out into the peritoneal cavity. Well, that's just going to lead to major infections, leading to peritonitis. And it'll also cause bleeding. So what'll happen is you'll get the patient will, they'll start dropping their blood pressure because now they're bleeding into the abdominal space, and you're losing fluid out of that intravascular space. The abdomen will become very rigid because all that stuff is going right into the abdomen. And you'll start seeing a drop in blood pressure and increasing heart rate, and hopefully it's not so significant that your patient loses consciousness, because they can pass away very quickly. So hopefully that occurs in the hospital, where you can go in quickly and repair that surgically, because you have to fill that hole in quickly, because it could create pretty significant problems. So what you try to do is prevent the ulcers from starting in the first place, or from it healing as quickly as possible. And there's several ways to do that. There's several surgeries that they do, and you'll see those different kinds of surgeries starting on page 1269. Sometimes they can just take out the piece of the stomach that is constantly getting the ulcers. Sometimes they can do a vagotomy where they cut a piece of that vagus nerve. So there's a couple different ways that that they manage a perforated stomach from ulcers, or somebody who has chronic peptic ulcer disease. So do kind of look through that, how to monitor and manage potential complications of a perforated ulcer. So your goal as a nurse: prevent the ulcer, improve the ulcer, prevent the hemorrhage from the ulcer, prevent the perforation of the ulcer, and to identify signs and symptoms of if those occur. So lots of patient teaching, following up, making sure your patient's not doing all those things, which is sometimes hard. You know, they love their coffee, they love to, they're smoking, it's very difficult. Once your patient does start hemorrhaging, if they're perforating, I need you to keep in mind that they will, they may start vomiting up the coffee grounds. They can get confused, especially if they're starting to get hypovolemic. They can get confused, and all of this stuff gets exponentially worse as the patient is older. The older the patient gets, all of these complications get exponentially worse. Okay, let's see. What else do I want you guys to know? So, yeah, spend some time on page 1270 and 1271, because I do need you to know about that. I want to talk next about obesity. Now I'm over on page 1272, because this is such an increasing epidemic in the United States. There's all kinds of weight loss programs. There's all kinds of teaching. School programs. Michelle Obama has a healthy lifestyles campaign. Nonetheless, Americans are still continuing to be large and get large. So the problem with obesity is it leads to significant other problems in health problems. Obese people and even overweight people are prone to hypertension, diabetes, kidney problems. There's all kinds of issues associated with being overweight. So a new kind of treatment, not that new, is bariatric surgery, where if a person has tried weight loss, other programs, and they've continued to fail, there are some bariatric options. And I do want you to be aware of the different kinds of procedures. And you'll see this figure 47.3 on page 1275. And I also want you to look over at chart 47.5, because not everybody's overweight can have these procedures. These are very risky procedures. One reason being, overweight patients don't heal as well because adipose tissue doesn't have any blood supply through it. You know this. If you cut a piece of steak, all the fat that's around that outside of the steak, there's no blood supply in there. And so when you cut through the skin of an overweight person to do some of these procedures that you see on page 1275, the healing is it's tricky. In addition, they're overweight, so after surgery, they're laying in bed, so you want them to do a lot of coughing and deep breathing because you're trying to prevent atelectasis, which can lead to pneumonia. So you need them coughing and deep breathing, but at the same time they have this big incision there, you want to prevent dehiscence, meaning that that wound is coming apart. So when you're teaching your patient postoperatively, how to care for that wound, one thing is to splint the wound. So you put a pillow over the wound and you hold it tight and then cough while you're putting pressure against that wound so that the wound doesn't dehiss. They are coming up with some new procedures now where it's laparoscopic. They're doing some of these Roux-en-Y, surgical bandings, that kind of thing. They're doing it laparoscopically so that the recovery is minimized and not as risky. However, sometimes, even though a patient meets other criteria, they still can't have the bariatric surgeries done. For example, if they are currently taking drugs and alcohol, if they have some kind of a reversible endocrine disorder that can fix the obesity some other way, like if they've got hypothyroidism or something like that, if we can fix the thyroid problem, they might start losing weight. If they have severe psychiatric illnesses, they're not a candidate for it. And if they have some kind of a cognitive impairment that they can't understand the risks and the benefits, because following these procedures, eating gets tricky. They can only have small meals. They should have 6 small meals a day. They can't mix food with water, so or any kind of liquid. So they would have their liquid, and then they have to wait 2 or 3 hours, and then they can have a small amount of food, and then they have to wait and have more liquids. You don't mix them together. After eating, they need to sit upright. You can't eat before bed because you're trying to prevent dumping syndrome, dumping syndrome is where somebody who's had gastric bypass eats and the food hits the stomach and then it like just flows through the rest of the GI tract and they have diarrhea or nausea or vomiting or something. That's kind of a big problem following bariatric surgeries. Anxiety is a big deal because it's a major surgery, so you got to kind of coach somebody before they go into surgery. So here you need to be very careful of where the patient is on the timeline and which nursing interventions fit really well in there. So at the time when somebody's getting ready to go home, that would be an excellent time to start teaching them about dumping syndrome. When they're getting ready to go into surgery, you don't want to teach them about dumping syndrome. You want to teach them what to expect in the operating room and what to, expect up on the floor, that we're going to have you coughing and deep breathing, that kind of stuff. So it's important that your nursing interventions match where they are in the process of having this bariatric surgery done. Another thing, when they return up to the unit following, and most of them are inpatient, all of them are inpatient right now, is you want to get them up moving as quick as possible. You want them turning from side to side. Now, keeping in mind these patients are extremely obese, so movement and mobility is very challenging. They will start losing weight, but not right away. So you want to position them, turning them from side to side. They need to be up in a Fowler's, like a low Fowler's position, not semi-Fowler's position. That just makes them a little bit more comfortable. And so then when they're getting ready to go home is when you can start teaching them about their diet. Now, it typically takes about a year for their weight to stabilize. So after they've had the surgery, it takes at least a year, sometimes a little bit longer, for their weight to get back down to, acceptable, where they want it to be. The problem is, depending on how long they've been overweight, the skin has been very stretched out and the skin does not return to its original state. So many of those patients have to go have what's called their pannus, and a pannus is this stretched out skin. They have to have that surgically removed. If you've ever seen The Biggest Loser, or one of those, you know, extreme weight loss shows, they lose a ton of weight, but then they also have to go in and have surgery because they have a bunch of excess skin folds that won't go away, like they're you know, underneath their triceps and the pannus in their abdomen. Sometimes that has to be removed surgically, but you need to tell the patient that you know, it's gonna be a while before they're able to do that. So I do want you to read through the rest of like page 1276, 1277 for some of the gastric cancers. I mean the bariatric surgeries. Now I want to talk about gastric cancers. Gastric cancer, that is not good news. So if your patient has gastric cancer, it's not, I mean, it's not quite as lethal as pancreatic cancer, but it's not good. It's not super common in the United States. It's very common in Japan. And what they have found is that there is an association between high salty and high smoked foods. In Japan eats a ton of smoked fish, and they smoke a lot. So they have very high rates of gastric cancer. And so now they're implementing gastric cancer screenings in Japan, kind of like we screen for colon cancer in the United States, because colon cancer is higher in the United States. Gastric cancer, the prognosis, it's not phenomenal. And nutrition is huge because the patients tend to lose their appetite. They don't want to eat, so there's a lot of weight loss. And when there's weight loss, then the person doesn't have the nutrients, the protein that they need to heal. Typically, once we find a gastric cancer, because oftentimes they'll come in with the same symptoms of GERD and peptic ulcer disease, so you think that's what it is, and so you treat it for that, and the cancer continues to grow. By the time they actually find the cancer, oftentimes it has already spread to the surrounding organs, like the liver and the pancreas. Sometimes up into the esophagus and the duodenum are often already affected. So by the time they find it, it's, you know, it's kind of advanced. They can do surgery on it. If it is advanced into the lymph nodes, same thing, where they'll do the chemotherapy, maybe radiation. Abdominal pain, weight loss. People complain of getting full really quickly. It's called satiety, early satiety, where they eat just a little bit, like, oh, I'm full already. Bloating after meals, nausea and vomiting. Those are all indications of gastric cancers. So again, if your patient has a malignancy and they've had surgery and maybe chemotherapy, now we need to try to support that patient as much as possible to give them the best quality of life, even though the quantity of their life might be reduced. So we're going to teach them how to reduce their anxiety, how to increase nutrition, lots of vitamin A, vitamin C, easy to digest foods. Again, if it's, you know, if they've had a total gastrectomy, they're going to need to be on their B12 shots, and you know, anti-nausea medication, something that increases peristalsis. And I worked at U of M for a lot of years in their multidisciplinary GI cancer clinic, and this was several years ago. And these patients, I had one patient in particular. He was a young guy, like, I don't know, 45 or 50, been diagnosed with gastric cancer. And he and his girlfriend, they were dancers. They loved to go to like square dances and stuff like that. And he just really wanted to enjoy his life, but he didn't feel good, wasn't hungry, couldn't eat. And back then, medical marijuana was not an option. However, it was in Ann Arbor, and, you know, there tends to be a little bit of marijuana in Ann Arbor. So this guy was able to get a hold of some marijuana and would smoke it, and it was phenomenal because it would increase his appetite. And so then he would eat, and he was actually able to prolong his life quite a bit and enjoy the quality of life, because then he and his girlfriend were able to go, they did, you know, probably another 6-8 months on the square dancing circuit, and they really enjoyed their time together, knowing that his time was a little bit short because of marijuana. So, you know, in Michigan now it is legal, so that this is not in your book, nor will it be on the test, but I'm just telling you from a personal standpoint, that is one of the benefits of medical marijuana, is that it does, one, reduce pain, reduce anxiety, and increase appetite, all things that your gastric patients need. So just keep that in mind. There are cancers of the small intestines, but that's super rare, so you don't need to know about that. Okay, so that's it, and now we'll do the lower GI tract, and then we'll be done for this unit. So, sweet. All right.